Hi, my name is Dr. Hilsden, and you're watching Knife Skills. Today I'm going to post a little different video than the previous videos I've been posting. This video is a conversation between myself and an emergency department colleague of mine, Dr. Frank Myslik, and we're talking about biliary ultrasound in the emergency department, one of our papers that was published in the Trauma and Acute Care Surgery Open Journal in 2018. And although that's a little bit in the past, that's a 2-year-old article, we're very close to publishing a follow-up on that paper, a prospective study, again, looking at the outcomes of ultrasound performed by emergency department doctors. So we talk about a few different things here: the cost benefits, the outcomes of this paper, as well as our future directions and future hopes for point of care ultrasound. And I hope you enjoy it. Welcome. My name is Dr. Richard Hilsden. I'm a general surgeon. I'm here with my colleague, Dr. Frank Myslik, and we're going to discuss with you our recent publication, Point of Care Biliary Ultrasound in the Emergency Department, Implications for Surgical Referral and Emergency Department Wait Times. So, Frank, at this stage, what's the current status of biliary ultrasound in the emergency department? How's it used?
Yeah, so we use POCUS quite a bit in the emergency department, but specifically for biliary ultrasound, I'd say it's quite variable. A lot of emergency physicians will use POCUS for various indications. The biliary aspect of it, some have actual training and have had lots of experience and feel very comfortable making decisions. Some will kind of take a gander and then maybe get a radiologic ultrasound after, and some won't even pick up the probe for it. That being said, there's quite a bit of uptake in biliary ultrasound, and to be honest, the literature's out there to support that we're quite good at it for the most part.
Yeah, and I've definitely seen an increase in the use of biliary ultrasound at our own hospital. Certainly as a general surgeon, the enthusiasm for making decisions based on an emergency department performed study is tepid at most. There are those of us who are starting to embrace it. And really, what our paper is hoping to demonstrate is really show how ultrasound is used in the emergency department, bring awareness to general surgeons that this is happening. There is good tests being performed that can assist surgeons in making decisions ultimately go to the operating room.
Yeah, that's right, Rich. I mean, the whole reason we've done this is because the biggest feedback I get from people and my own colleagues is that, yeah, it's great I can do a biliary ultrasound, but the surgeon's not going to listen to it, so why bother? For me, it's a data point. It always adds stuff. It's great to know what you're fighting and it can help my own decision making. But I do get the argument. A lot of times if I can see it and just refer, that would be my goal. So yeah, that's kind of the onus for why I got involved in this project.
Absolutely. And so what did we do? What was exactly the design of our study, and how did we help add to the literature?
Yeah, so like I said, the variability is out there for how emergency physicians are trained, because it's not a standard of care as part of our training program. But just before we could do anything as a perspective, we had to know, what is our current state? So we identified kind of super users of biliary ultrasound for point of care in our emergency department. And of the 10 physicians that we identified, we looked back at the last 6 months, and these were full-time academic emerge docs. And we looked at how many they did, and ultimately we have an archiving database for all our ultrasounds at our department. So we looked back and said, when they were actually did the biliary ultrasound, what happened to them? How many went home, how many stayed, how many were referred? So we had at our institution 283 patients that were seen over a 6-month period. Of these, and these are all people that had point-of-care biliary ultrasound. An emerge physician felt that was an indicated part of their exam, whether it was their highest suspicion or just part of their kind of abdominal workup, I'm not sure. But it was, these people felt they deserved an ultrasound of the gallbladder. Of those, basically, we had 283 people. Of that, 118 of them were just sent home without any other kind of follow-up imaging or anything. And ultimately, these people didn't even require any surgery. So of those, the rest of those that were actually referred, those patients were actually found that 43% of them ultimately had a cholecystectomy. So from an emerge physician who identified on their POCUS that there was a reason to refer for a biliary reason to a general surgeon, 43% of those had a cholecystectomy as their ultimate disposition.
Yeah, and I think those numbers are really interesting because we mentioned that more than 100 patients out of the 283 had ultrasounds. The emergency doctor was confident that the point of care ultrasound ruled out in their mind significant biliary pathology and discharged those patients. And it's also important to note that none of those patients returned to the emergency department requiring surgery for their gallbladder.
Yeah, and I thought it was fascinating. So, if you, as a clinical suspicion, as an emerge doc, if you thought they deserved a point of care, I would argue you probably thought they, in real life, probably needed a formal. So those people didn't even need an imaging. That's awesome to save that much.
Absolutely, and the patients both saved time in the emergency department. We demonstrated that as a result in our study. But what we didn't specifically look at was cost, and we can imagine that if there was fewer formal radiology department ultrasounds done, there'd be a cost savings.
Yeah, not only from the absolute amount of ultrasounds, but time in department, all those sort of things, return visits. So one thing that unfortunately we don't have is we don't have 24-hour access to these radiologic ultrasounds. I'm certainly not arguing they don't need them in some capacity in some specific circumstances, but let's say I see someone at night, at like midnight, I can't get an ultrasound then, so I have to bring that patient back. And by returning to the emergency department, there's costs with administration registration, there's costs with just getting back in the department, like the stay. So there's all these external costs we even think of beyond just the simple ultrasound component.
Another outcome that I think is interesting, you mentioned that the 43% that were referred to general surgery ended up going on and having their gallbladder removed. It's also interesting to look at the specificity really of ultrasound in our study. As you mentioned, we're not the first to publish data on emergency department ultrasounds and the sensitivity and specificities of the test, but we had a unique outcome. We actually were most interested in how the ultrasound predicted the need for surgery.
Yeah, and that's the thing. We weren't trying to prove, can we do it? That's been shown. So emerge docs and just physicians in general with training can do biliary POCUS. That's not that big thing. So our results echoed that, but agreeable that we're the first to kind of look at if they got the POCUS and identified gallstone, which was one of the biggest factors, they got their gallbladder out most of the time.
That's right. We had a 92% specificity for patients who had a gallstone on their ultrasound when they had appropriately clinical indication to have a biliary POCUS, and ultimately referred to general surgery. So that's an exciting outcome. And again, this is unique in our study because typically when biliary point of care ultrasound has been evaluated before, the gold standard is the radiology department ultrasound.
Right. Yeah.
But we actually took patients to the operating room.
Yeah.
And in this case, actually all of the patients who went to the operating room did have biliary disease proved on pathology.
Right. So to me, and obviously as a surgeon, OR time is a very limiting factor sometimes. So when you actually have the ability to do that when the OR is available, whether that's on call or overnight, if we can get you those patients quicker, I imagine for you it's a win because you can get gallbladders out sooner, avoid less complications, and you just kind of avoid a longer term consequence of that patient having that biliary disease.
And this paper really gives us even more confidence that when we have an experienced emergency provider doing a point of care ultrasound, finding gallstones, finding a symptomatic patient, that the next best step for that patient is to have their gallbladder removed.
That's right. Yeah. And now, again, I'm talking about patients that had biliary disease identified by trained providers. And I think you hit the nail on the head. This isn't just like the lay of the land of how we have almost 60, 70 emerge docs in our department. And I wouldn't trust all of them with doing the biliary POCUS. But that being said, this study for me shows that if we can train our emerge docs, we can probably expedite a lot of the care of our patients and triage them to appropriate imaging. So it gives me some fodder to my own group to say, yeah, if we train you guys, this can make a big difference.
So Frank, where do we go from here as far as research? What's the next question? What's the next pathway for us to establish?
Well, before we can do anything prospective in terms of actual outcomes with the patients, the biggest thing is, can you show and prove to a surgeon that a biliary POCUS is just as good in their surgical decision making as a radiologic? And in other words, does a radiology ultrasound add anything to all patients? Now, I'm sure there are times where it might add something in terms of extra information that maybe we can't provide. But I would argue a lot of times if the clinical story fits, we all agree that it's there. The point of care ultrasound shows a gallstone. Other than proving what we already know, what does the radiologic ultrasound do? And what we need to do is if we provide the same information to the surgeon and we ask him to make a surgical decision, would they make the same decision? And I think that's what we need to look at next.
Awesome. Well, thanks, Frank, for sitting down with me and discussing our paper. I'm going to put a link to the article below. It's in the Trauma and Acute Care Surgery Open, I should say. And the link is in the description below.
Cool. Thanks a lot, Rich.
Thanks.
Good.
That's perfect.
There you go.
Minor foot by the end, but who cares? And good.
Well, that just gives it a sense of realism.
Yeah, exactly.
No,
That's right.
I mean that honestly. Like
you're a very natural man. It's so perfect.
There's certain things I'm good at. I'm good at speaking.
I was like 9. Yeah, you are. That's perfect. I was like 9 minutes, but that's perfect.
Oh, that's okay. Like again, who cares if
Who cares is all. But it's good. Thanks, man. Take the time now. Make sure that you're.
It's actually interesting. I never thought of doing that stuff before.